This conference will
Okay,
now
it's
be
recording.
recorded.
Okay, so today we'll be touching upon the clinical science mainly. So first, what I'll do is that I'll just take you through how to describe normal findings in an individual. Quite often, when you describe the normal findings, we do see significant amount of mistakes done. So what I'm going to take you through is how to describe a normal finding. So before that, just quickly revise what you are supposed to see in the inspection. So we have already discussed. So we need to look at what are the main components, what are the broad components you have to see in inspection. What are the broad components we have to see in inspection? I just asked a question. What are the broad components you have to see in? Okay, Shruti has put as bony environment, mediastinal position, volume of the lung, expansile function of the lung, and the skin. Okay, so that is what I have put it as question here. So I have just put it as how is the shape of the chest, how is the symmetry of the chest, is there any sternal deformity, is there any spinal deformity. So the first four questions will address the bony environment. So how you elaborate it? The normal shape of the chest is elliptical and it is bilaterally symmetrical. And in a normal individual, you don't see any sternal deformity, any depression or projection of the sternum, and no spinal deformity also. So this is how you describe the normal things in inspection. Going on to the next one, it is the mediastinal position. Two things we have to see in mediastinal positions. One is tracheal position, other is apical impulse. So what finding in inspection, you will tell that trachea is in midline. What finding in inspection, I think I've already told you about trial sign. The finding which that is in deviation. When will you tell it is in midline? If it is in midline, what will be the finding? What are the possible combination of findings when you will tell that trachea is in midline? No hollowing between, no difference. Okay, Roshni has given no difference in the sternum-mastoid on both sides. Chandani has mentioned no prominence of clavicular head or sternocleidomastoid on either side. Okay. See, basically, you can tell trachea and midline due to 2 or 3 combination of findings. Either when both the side the clavicular head of the sternum-mastoid is seen, both the side it is seen, and it is equally prominent. Okay, so then you will tell that trachea is in midline. Or many times both the side clavicular head will not be seen. Okay, so the by definition undue prominence of the clavicular head on one side. So there are only two possible reasons when you will tell it is in midline, when the clavicular head is equally prominent on both sides, or when the clavicular head is not seen at all on both sides. But if there is an asymmetry, then you need to make a decision on that. So that is tracheal position. Then you will tell about the apical impulse. So you will just mention where the apical impulse is seen. Generally, when the history is focused more on the respiratory system and you are following the template for inspection of respiratory system, generally you need not elaborate about hyperdynamic apex and all those things. It's enough if you tell the location of the apex alone. Then if there is any change in the volume, this already I have told you what are the components. So you will tell it as no supraclavicular or infraclavicular hollowing or fullness. See, remember to tell hollowing or fullness, because even fullness is abnormal. And no drooping of the shoulder, winging of the scapula. Again, no crowding or fullness of the intercostal space. So two places you can either get a hollowing or a fullness. One is the supraclavicular and the infraclavicular region, another is the intercostal spaces. Then you will tell how is the chest expansion. So generally chest should expand equally on both sides. Then no scar, dilated veins, sinuses or discharge. So this is how you describe the inspection finding in a normal individual. If the findings are normal, this is how you will, these are the phrases or words you will use to elaborate. Is the description clear? Is the description of inspection in a normal individual clear? Okay. So this is just a revision. We are just revising the what we have already discussed. So now going into the palpation. So palpation, I already told you, you will be looking into the trachea again. So you will palpate the trachea and tell the trachea is in midline. So when you palpate the trachea, what finding will make you tell that trachea is in midline? When you palpate the trachea, what finding will make you, when you palpate? No, I'm not asking about the method. What finding? What will you perceive in your hand? Both sides. What will you feel? Equal space. No, you are palpating. Resistance, Meghana, very good. So equal resistance on both sides. When you try to insinuate the finger, again, position of the trachea and palpation, you go by the insinuation method. Don't rely on the screening method. Screening is method just for the sake of initial idea to know whether the trachea is deviated or not. But you have to go by the insinuation method, and the resistance has to be equal. And the resistance has to be equal up to the suprasternal notch. So even if the resistance is more on one side in the lower part of the trachea, then you will tell that the trachea is deviated. Okay. So again, palpation of the apical impulse, you will only tell which site it is felt, and no need to tell about the character. In cardiovascular system, you do elaborate about the character, you do tell about the thrill felt in the apex. Those things are not required. In case if it is felt, then you have to again elaborate the cardiovascular system in detail, because it means that the patient has two problems, respiratory as well as cardiovascular. Now expansion of the chest, as I told you, you will elaborate as superior, anterior and posterior, and it is equal on both sides. Tactile vocal fremitus, and no need to mention this tactile fremitus. Do you know what is tactile fremitus? We don't insist on that nowadays. Tactile fremitus. Tactile vocal fremitus, I told you what was tactile vocal fremitus. If it is just tactile fremitus, same as VR and palpation. No, so that is tactile vocal fremitus. See, the equivalent of vocal resonance is tactile vocal fremitus. My question is just tactile fremitus without the word vocal. Smriti has mentioned trying to pick up feeling of crackles. So basically it is palpable crackles. The palpable crackles is what is called tactile fremitus. Sometimes it can be even a palpable rub. So basically a palpable added sound is called tactile fremitus, but it's not required. You can just skip that at your level now. We don't insist on that. Then measurements. Measurements, again you look at the AP diameter and the transverse diameter. You also look at the chest expansion, total chest expansion, right and the left hemithorax. So I have not gone much into the measurements part of it. Don't bother about it much. But generally, which is more reliable for chest expansion? Inspection or palpation or measurements? Inspections. You always remember that. So spend more time in inspection to study the chest expansion, because that is what is more reliable. Okay. Is description of the palpation clear? Description of palpation of respiratory system in a normal individual. Is it clear? Okay. Now going into the percussion. So percussion, as already told you, you will be percussing direct percussion of the clavicle. It's not that valuable, but for sake of completion, you can put it. The findings are very variable, so I don't want to discuss the direct percussion as of now. So it's one of the things we'll take it up later on when we discuss some case scenarios. Main areas you need to concentrate is the supraclavicular, infraclavicular, mammary region in the anterior part of the chest, axillary and infraaxillary region on the lateral part, and suprascapular, interscapular, and infrascapular in the posterior part. Okay, so the normal thing is resonant. And for a beginner, and even for most of us, when we palpate, some parts of the lung are more resonant, some part of the lung are not resonant at all. So can you tell some areas where it is very difficult to get the resonance, even in normal individuals, even in thin-built individuals, normal thin-built males, certain areas where you may really struggle to get the resonance? Tell the area, interscapular, drop space. Now forget about the drop space as well. For your cardiac, the cardiac and liver is actually dull. Fifth intercostal space. I think your answer reflects that most of you have not actually percussed the chest at all. Am I right? Between the clavicle and the scapula. Between the clavicle and the scapula on the upper aspect. Smriti, which place you are exactly telling? Smriti is, I think, close to the answer, but it's not still clear which area she is mentioning. Supraclavicular, infraclavicular, corresponding to the apex. Apex means, see, apex can be accessed through all three areas. Supraclavicular, suprascapular, and axilla. All the three places you can, high up in the axilla, you can access the apex. Okay, give the answer. Most difficult to place to get the resonance is the suprascapular, because you will get the trapezius, thick band of trapezius coming there, and the shoulder strap of muscles here, this place. So suprascapular region is the place where it is most difficult to get the resonance. Even if you percuss in healthy individuals, it will appear as if it is little impaired or dull. The second place where you may really struggle to get the resonance is interscapular area. Some of you mentioned it. So in interscapular area and the suprascapular area is little difficult, but the worst is the suprascapular. So which area you will get the best resonance? Which area you will get comfortable resonance? Now, Sana has mentioned, why do we percuss directly on the clavicles? I'll come back to that later. It is to look at clavicular percussion. We'll leave it now. It's a controversial topic, not clear about the clinical usefulness. We'll take up little. Okay, so most resonant will be infraclavicular and upper mammary. Okay, so infraclavicular and upper mammary, somewhere in the second intercostal space, third intercostal space, close to the midline. That is the place where it will be resonant. Okay, so this is how you will describe the percussion. Now coming to auscultation. So you need to comment on four things in auscultation. How is the breath sounds? Is it normal vesicular in all region? Actually, the vesicular breath sound is a misnomer, but still we use that terminology only now. So is the breath sounds normal in intensity in all the regions? How is there any bronchial breathing? Is there any added sounds? By added sounds, I mean any crackles, wheeze, or any rub. And is there any how is the vocal resonance in all the regions. So 4 things you will elaborate and mention that you have to tell it in all regions, specifically breath sounds and vocal resonance. You have to specifically tell it is in all regions. Okay. So I think with this we come to the end of the description of normal patient. Before I go into the abnormal picture, so is it clear about what words you will use, what phrase you will use, and how you will arrange the description in a normal individual? Smriti has mentioned how to distinguish between 3 added sounds. Okay. See, the crackles is a discontinuous sound. You know that it is something like crushing of the leaves. So that's how the crackles actually occur. So crackles actually it's a discontinuous sound. It will be like a crushing of the leaves or bubbling of the um, um, when you create a bubble in a fluid, something like that. Wheeze is musical sound. I think you know that. Clear cut musical sound is wheeze. Rub will be very much similar to crackle only, but I think it can be differentiated by certain techniques. I already told you when you cough, the crackles will change, rub will not change. And when you press the diaphragm on the chest wall firmly, rub will increase in the intensity, whereas crackles will not change. Okay, so crackles are discontinuous sounds, something like a crushing of the leaves or air bubbling through water. Wheeze is musical sound. I think most of you will be aware of how a wheeze will sound like. Rub is also a discontinuous sound, but it will not be altered by cough, and the intensity will increase when you press the diaphragm on the chest wall firmly. Is that clear? The differentiating the 3 sounds? No, both. Smriti has mentioned that coughing more to identify crackles of alveolar and ductal origin. So both will increase. See, cough will actually change both alveolar crackles as well as airway crackles. Both will have an effect. Okay, fine. Now going into the description and disease states. Okay, now going into the disease state. So what I will do is I will use the X-ray first just to tell what could be the diagnosis. Then we'll see what finding this kind of a respiratory problem will have an inspection, palpation, percussion, and auscultation. Okay. So can one of you tell just the findings, what you are able to appreciate? Doesn't matter if you are not able to pick up all the findings, but at least the main findings in the X-ray. Most convincing findings or glaring findings in the X-ray. Now I want the findings. Just tell the findings. Haridev has put it as pleural effusion, but what are the findings? When you see the X-ray, basically what are the main findings? Okay. Milone has mentioned that opacity on the left lower lobe of the lung. Okay. Roshni has mentioned homogeneous opacity. Good. Denting of the angles. Anything else? One more finding we are not picking up. Vascular markings absent. Okay. Anything else? So I'll just go through the answers what you have put. Opacity on the left lung, haziness in the middle and the lower, blunting of the costophrenic angle. Okay. I'll go to the X-ray now. Now this finding, basically when you look at the X-ray, what is really striking there is two things. One is the left lung is not clearly visualized at all. You are able to see a big white opacity. So this we call it as homogeneous because it is as same as the heart. Okay. And you are not able to see the angle. You're not able to see the angle. You're not able to see the costophrenic angle. You are not able to see the cardiophrenic angle also. And as the opacity is seen in the upper part, you are able to see an internal translucence. Okay. If you carefully see, the trachea appears to go towards the right side. Trachea appears to go towards the right side, and the heart is pushed more towards the right side. Okay. And on the this is on the left side. Right side also there is some amount of increase in the airway opacity is marginally prominent. So these are the findings. Okay. Are you able to appreciate the findings when I describe? So Alan has mentioned right side of the sternum also opaque. Yeah, see, that is the right side of the sternum is opaque because the heart is moved to the right side. Heart has crossed the right parasternal line. So that is why it is white. Okay, anyway. So this is a finding which is consistent with left-sided massive pleural effusion, which is causing mediastinal shift towards the right. Okay. So now we have to take what could be the findings in inspection. So such is the problem in the patient in X-ray. So when you examine the patient, what could be the finding you will have in inspection? So you have to go by the order I have already given you. What will be the finding in inspection? Sana has mentioned trial sign positive. No, it should be the complete description. Now, we know that we need to look at least five things in the inspection, isn't it? So don't be in a hurry to post the answer. You take time and put, no issues. Roshni has put bone normal, mediastinal shift to the right, fullness in the left, okay, decreased expansion on the left. I'll give some time, you can attempt because we need to go slow here. If I rush through here, you may not be able to understand the concepts. Harini has put bony environment is normal, trial sign okay, volume change is normal, decreased expansion on the left. Okay, I'll just wait for one or two answers, then I'll go for the discussion. Arushi has mentioned, okay, now only I'm seeing the answers. On trachea appears deviated to the right side, apical impulse not palpable. Fullness in the left mammary region, chest expansion appears reduced on the left side. Okay, so we'll go back to the slides which already we have seen. See, have you heard a phrase called full house clinical picture? Have you heard of a phrase called, usually we among doctors we discuss, treating doctors we discuss, that patient is having a full house clinical features. So what do you mean by full house? You have not heard. Okay, full house clinical features, or the abnormality of the blood test is full house. Okay. See, full house is when a particular patient has all the features. Yes, Pankti has put, very good. So when a particular individual has all the classical features which is expected in a particular disease. Okay. Now what proportion of these patients, for example, if you have 100 patients with pleural effusion, how many will have full house? Let's assume you have 100, less than 10%, very few, 20%. Okay, the number is less, somewhere around, maybe we can tell around 10 to 20%. So most of them will have around 50% to two-thirds of what we expect, and most of them will not have all the things. Okay, so I'll go by that. So whatever description I am giving is for an individual who has all the features. Okay, we can call it as the full house features, but in practice, when you see the patient, actually it may vary. Some may even contradict. For example, all the features of pleural effusion will be present, but the trachea will be deviated to the same side. Okay, or else all the features will be present, but the chest expansion will not be affected. Okay, so there can be variations in the clinical signs when you see the patient. You should always remember that. So a lot of probability comes there. So when you, at the end of the clinical examination, you will have a set of findings which will favor the diagnosis. You will have a set of findings which will the ones that turn up our exam cases will be full house too. Smriti has asked this question. No, respiratory system, actually you will have very less amount of full house cases. It will be mixture of things. So that is why I'm telling you have to know to discuss the findings. Full house you don't get that commonly. Cardiovascular you do get sometimes. Abdomen you get, but respiratory the full house findings are not that common even during exams. Okay. Anyway, don't bother about the exams now. The purpose is to learn, right? Now, so which means that you need to judge based on the combination of findings. Okay. So now let's take the inspection part. So pleural effusion usually does not change the shape of the chest. Okay. The symmetry of the chest is more or less preserved, and it usually does not cause any spinal deformity or spondyl deformity. So bony environment will be normal. Trachea will be deviated to the opposite side. For example, here it is left side massive effusion, so trachea will be shifted to opposite side. Apical impulse on the left side. This is a left massive pleural effusion, so apical impulse may not be seen. Now, since it is a massive pleural effusion, predominantly almost below the second intercostal space fully, I will expect fullness of the intercostal space. So it's opposite of crowding of ribs. So there may be fullness of the intercostal space, and probably supraclavicular hollowness or supraclavicular or infraclavicular fullness will not be there. So only finding you may have is fullness of the intercostal space on the lower part. Expansion of the chest is likely to be affected on the left side significantly because it's a massive effusion, and you do not expect to get any kind of a scar or any dilated veins. Okay, so is the description of the inspection finding in pleural effusion clear? So I have just described the inspection finding in pleural effusion. Okay, so I have not mentioned you the variations. I am not touching the variations now. We'll touch the variations at a later point of time. Now going to the palpations. Now Rachana wants me to repeat it again. I'll quickly repeat it, Rachana. So bony environment will be normal. Trachea will be deviated to the right. Apical impulse will not be seen because it's a left massive pleural effusion. Signs of volume change may be minimal in the form of fullness of the intercostal spaces in the lower part, because in the lower part the pleural fluid will be tense, so therefore it may cause fullness of the intercostal space. Rest will be normal. Chest expansion will be decreased on the left side, and the skin will be normal. Okay, so now can you try the palpatory findings? Can you try the palpatory findings? Palpatory finding is a left massive pleural effusion. So Roshni has mentioned inspectory findings confirm no tactile fremitus, marked decrease in the tactile focal fremitus. You have to tell the location. No, which are all the location? Probably left massive pleural effusion. So where will be the decrease in the tactile vocal fremitus? Which areas? Which areas? You have to tell in areas, isn't it? Palpation. See, from palpation, you will tell suprascapular, infrascapular, interscapular, supraclavicular, infraclavicular, left mammary. So pleural effusion, where will be the highest part of the fluid? Where will be the highest part of the fluid? Anterior, lateral chest or posterior chest? When you have the fluid level, it will be lateral. Okay. So where all you will have the impairment in the tactile vocal fremitus? Okay, axillary as well as infraaxillary, very good. Anteriorly, 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 mammary, yes. Posteriorly, infrascapular and interscapular, very good. So this is what you expect in this patient. So let's just go into the palpatory finding. So trachea will be deviated towards the right side, so that you will confirm. Apical impulse you will not be able to feel. Chest expansion will be decreased. Okay, chest expansion will be decreased, probably in the anterior and the posterior and possibly superior. So that you have to take it on the case by case, but generally chest expansion will be significantly decreased in the left side. And tactile vocal fremitus will be decreased in the axillary and the infraaxillary, mammary region, interscapular and infrascapular. Okay, so I'm not going into the measurements now. Okay, is the palpatory findings in pleural effusion clear? Is the palpatory findings in the pleural effusion clear? Okay, one question is, why is tactile fremitus decreased? See, tactile fremitus is decreased at the position where the pleural fluid is present, because I think I explained it to you earlier also. What I told was, in the when there is a fluid, the frequencies will be reflected back. It's true that the fluid is a better conductor, but what happens in pleural effusion is, the sound which is produced at the vocal cord, when it reaches the interface of the lung and the pleura, it gets reflected back into the lung itself. So it gets reflected back into the lung. The reason is not clear. That is why tactile vocal fremitus is decreased. Now, at the upper margin of the pleural fluid, since you have asked that question, at the margin of the pleural fluid, we tell above the level of effusion, it will be tactile vocal fremitus can be increased. Okay, I'm not going into that now, because that is not true in all patients. So let's not bother about the findings in pleural effusion above the level of pleural effusion. So I'm not going into that because it may confuse you a lot. So let's finish the MBBS level knowledge first. So as an MBBS student, you should be aware that tactile vocal fremitus will be decreased in these areas. Let me repeat it: mammary, axillary and infraaxillary, interscapular and infrascapular. So these are the region where the changes, you may have changes above the level of effusion. Let's take it at a later point of time. Okay. Now, measurements, again, the chest expansion will be decreased. Now, what findings you will get in percussion? What findings you will get in percussion? So Roshni has put stony dullness in mammary, axillary, infraaxillary, yeah. The same areas where you expect the tactile vocal fremitus to be decreased, the same place you will get a stony dullness. Okay. So when will you tell it is stony dull? When will you conclude that it is stony dull? So I'm just attempting to revise what we have. So a dull percussion note plus when the finger hurts. So that is when you will tell it is a stony dull. Okay. So percussion is quite straightforward. Now going to the auscultation. So what finding you will have an auscultation in this case of left massive pleural effusion? What findings you will get? So decreased breath sounds on the same areas, absent breath sounds on output, VR will be decreased. Okay, most of you have mentioned it is decreased breath sound. Okay, so it will be absent or decreased breath sound depending on the how much is the fluid interface is there. Absent or decreased breath sounds on the left side, almost in the same region. So in the so generally, even though percussion note is stony dull in the axilla, most of the time some amount of breath sounds will be heard in the axilla also. Okay, so it will be usually little lower than what you actually expect in the tactile vocal fremitus. So breath sounds are little bit more heard in the interscapular area and in the axilla. So two places where I already told that the percussion will be stony dull and tactile vocal fremitus will be decreased, but these two areas you may hear some amount of breath sound. So generally what you expect is a decrease or absent breath sounds in the mammary region, infraaxillary region and the infrascapular region. Okay, and vocal resonance also will be decreased. So again, above the level of pleural effusion, you may have some change in the vocal resonance. I'm not going into that now. So this is what you will be able to appreciate. Okay. Now, will you have any findings in the right lung? Will you have any abnormal findings in the right lung? The same patient who has a massive left-sided pleural effusion, is it possible that the patient may have some abnormal findings in the what findings it may be present? What findings may be present? Now, why should there be a crowding of ribs on the right side? Now think. Okay, but generally, even if so Smithy has mentioned that decreased breath sound due to reduced chest expansion caused by deviation of the mediastinum. No, mediastinum will not compress the lung to that extent. Okay. Evidence of cause of effusion. No. Same infective etiology, right lung. Okay. So you may have some crackles. I'll agree. You may have some crackles on the right side. I think Chandni has got the answer. Bronchial breathing as trachea is deviated to the right. Okay. So the trachea is grossly deviated to the right. I think I showed you. I'll show it again in the X-ray now. See, you can see that the trachea is deviated to the right. So what will happen when this gets deviated? When the trachea gets grossly deviated to the right side, you may have slight increase in the vocal resonance, here, and harsh breath sounds. So breath sounds could be harsh. It may not be absent, it not be increased, but it will be like little bit harsh. Okay, so when you remember this always, when the trachea is deviated, especially when the trachea is pushed to the opposite side rather than being pulled. So it may have some secondary findings in the right upper lobe region. Is it clear? The findings you may have in the right upper lobe region as a result of deviation of trachea to the right. Is that clear? Okay, fine. So this is the findings in pleural effusions. Any doubts you have in examination findings in pleural effusions? I have not told about the trop space. We'll take trop space at a later point of time. Trop space is relevant in left-sided pleural effusion, so I'll take trop space at a later point of time. So that's not a very diagnostically high, it's not a high yield topic, so don't bother about it now. So is there any doubts in the clinical signs of massive pleural effusion before I go to the Next pathology. Haridev Shankar has mentioned scar of previous pleural tap. Pleural tapping rarely causes any scar. Only when they keep a when they put the intercostal drain, then only scarring will be there. Smriti Sardi asks, could you repeat the auscultatory findings on the left side where the breath sounds are heard better? Now, two places where the breath sounds can be heard, not completely absent, is the interscapular area and the axilla. Because interscapular area and the axilla, I told that you may have a percussion which is tone needle, and you may have a vocal fremitus which is decreased. So that is the exception. So two places. Sarthak has raised why we are increased on the right side. See, on the right side, see the trachea is deviated to the right. Trachea is deviated to the right. Trachea is supposed to go straight. Trachea is deviated towards the right. So when the trachea is deviated towards the right, what happens? The trachea comes more close to the right upper lobe region. The main bronchus comes more close to the right upper lobe region. So because of this, due to the pure proximity of the trachea towards the right side, vocal resonance will be increased on the right side. That's on the upper part only. A small area, vocal resonance will be increased. Is that clear? Okay. So now we'll go to the next scenario. I'll give you the next picture. So can you just tell the findings of the X-ray? Then we'll see the clinical correlation as we did for the earlier one. Alan has put hilar opacities. See which hilum, right or left hilum, or both sides? Soumya has mentioned cavitation. So you need to mention the location. Where is the cavity? Emphysematous lung extending about 10th rib. Okay. See, first you see whether there is an opacity or not. Is there an abnormal opacity seen in the X-ray or not? Is there an abnormal opacity seen in any of the lung fields? I'll give you a clue. Priyanka has mentioned right lower lobe. Right lower lobe. So can you describe that opacity on the right lower lobe? Can you describe the opacity on the right lower lobe? Is it a homogeneous opacity or a non-homogeneous opacity? Is it a homogeneous opacity? It's a non-homogeneous opacity. Okay. So with prominent air bronchograms. Very good. So there is a okay. So now, so I'll just describe the finding. So what you see is here. Here you are able to see an opacity. See, X-ray is actually divided into zones. Upper zones, mid zone and lower zone. The first two rib, whenever you see the field, you see the anterior margin of the rib. So I'm just look at the cursor. I'm just tracing the first rib from posterior to anterior. So first rib is starting here. It is turning like this. This is the anterior end of the first rib. Anterior end of the first rib. Okay. Now I am taking the second rib and tracing the second rib. This is the anterior end of the second rib, somewhere here, anterior end of the second rib. Then comes the third rib. Okay, so here is the third rib. This is the fourth rib. This is the fifth rib. This is the sixth rib. Okay, is it clear? Were you able to understand, to identify the anterior margin of the ribs? Were you able to, because I showed it to the cursor, were you able to understand Okay, Pulkit feels you are not able to understand. Okay, I'll repeat it again. Pulkit, just concentrate on the cursor. Just follow the cursor. See, here is the first rib. I'm just tracing the posterior aspect of the first rib. So this is the first rib is turning like this and it is coming anterior. This is the anterior margin of the first rib. Okay. So then I go to this is the second rib. So I'm following the rib from the posterior to the anterior. It's turning. And so this is the second rib. Okay. Then this is the third rib. Posterior aspect, I'm turning. This is the anterior margin of the third rib. Okay. So now this is the anterior margin of the fourth rib, anterior margin of the fifth rib, anterior margin of the sixth rib. Okay. Are you able to follow? Otherwise, I'll mark it at a later point of time. Okay. So now, why I wanted you to identify the anterior margin of the ribs is because up to the first two rib, it is upper zone. So this is the upper zone. From the second rib to the fourth rib, it is the mid zone. Below the fourth rib, it is the lower zone. So upper zone, mid zone, and lower zone. Now here the opacity is localized to which zone? Predominantly opacity is localized to which zone? Lower zone. Okay. So what you see is a lower zone non-homogeneous opacity with some amount of air bronchogram. Okay. So there are also some additional findings like you are able to see the hilum, both the hilum appears to be prominent. So that is one finding you can probably tell. And there is some amount of dilatation, round like structure. These are actually end on appearance. So don't bother about it now. So when you see a non-homogeneous opacity in the right lower zone with air bronchogram, this is probably a right lower lobe consolidation. Okay, so this is a right lower lobe consolidation. So now what we are going to look at is the inspection, palpation, percussion, and auscultation findings in right lower lobe consolidation. Okay, so that's what we are going to take up now. So now you have to tell me the inspectory finding in right lower lobe consolidation. So what are the inspectory finding you may have in right lower lobe consolidation? So Sarthak is not able to appreciate the air bronchogram. Doesn't matter, that's okay. See, air bronchogram means between the opacity you are able to see some translucency, isn't it? That is called air bronchogram. It is not dense white. It is whitish, but internally there are some black opacities. So that is what is called. Okay, Smriti feels that trachea is deviated to the right side. See, there is also some amount of rotation of the X-ray. I'm not going into the chest X-ray interpretation, so let's take it a little bit later. So first, Roshni has put as bony cage is normal, no mediastinal shift, no significant fullness or hollowness, expansion decrease in the right mammary region, skin is normal. Shruti has mentioned bony environment is normal. Mediastinum is normal, volume is normal, chest expansion is reduced on the right side, skin is normal. Okay. So now let me go into the findings. And I think you have put the correct answers. In lung consolidation, you may not have much of an abnormal finding. Shape of bony environment will be normal. Mediastinal position will be undisplaced. Remember that it will not cause deviation of the trachea. And apical impulse will not be displaced. There will not be any evidence of change in the volume of the lung. It will remain static. Lung expansion will be affected on the right side, mainly the lower part. So anterior and the posterior expansion on the right side will be affected and skin will be normal. Okay, so the only finding you will have on inspection of right lower lobe consolidation will be decreased in the chest expansion. Okay, so only finding will be decreased in the chest expansion. Is that clear now? Inspection finding in right lower lobe consolidation, the only finding you will have will be decrease in the chest expansion. There will not be any mediastinal shift. There will not be any evidence of volume loss or volume gain. Okay. Now, can you guess the findings in palpation? Can you guess the findings in palpation? So, what finding you will get in palpation? Now, Rachana has asked, sir, won't there be any volume increase in consolidation? No, volume will remain the same because air will be replaced by the alveolar exudates. So that is why the lung becomes like a liver. The volume of the lung remains the same. It does not increase. I mean the expand net volume. So Roshni has mentioned inspectory findings confirm decrease in the tactile vocal fermenters in the right mammary. Shruti has mentioned trachea and midline, apical impulse in the left space, chest expansion, AP reduced, okay. Tactile fermenters increased in the right mammary region. Gayatri has mentioned respiratory movement decreased, total local fermenters increased, okay. Okay. So now we'll go to the answer now. So in palpation, what happens is, we know that the trachea will be in midline, apical impulse will be normal, chest expansion will be affected. That we have seen the inspection. Now tactile vocal fermenters will be increased in the area over the consolidation. Understand that. Already I told you, when we produce the sound 1, it produces 2 set of frequencies. The lower frequencies and higher frequencies. Already I told you, normally a normal lung will filter the low frequency vibrations, and therefore all the frequencies will not feel the chest wall. But when there is a consolidation, the filtration function of the lung is lost. The filtration function of the lung is lost. So when the filtration function, I mean the filtration of the sound. So when the filtration function of the lung is lost, you will hear a sound in the chest wall which is identical to what you hear at the vocal cord. So whatever is produced at the vocal cord will fully be transmitted up to the chest wall. So that is why tactile vocal fermenters will be increased in the region corresponding to the right lower lobe. So corresponding the right lower lobe will be more of a infrascapular, infraaxillary and upper mammary region. Sorry, anterior part of the chest will not be affected. It will be only the posterior and the lateral. So infraaxillary region and the infrascapular region. Interscapular may or may not be affected, but looking at the X-ray, what I showed you, it is not a dense consolidation of the right lower lobe. It is a more of a patchy consolidation of the right lower lobe. So probably in this patient, in the X-ray, what I showed you, the only finding you will have will be increase in the tactile vocal fermenters in the infrascapular region, because that area is small area. So probably infraaxillary also will not be affected there. Is the finding clear? Is the explanation clear on why I am telling the finding the tactile vocal fermenters will be increased only in the infrascapular region, not in the infraaxillary region? Okay, but generally if it is a dense right lower lobe consolidation, if it's a dense right lower lobe consolidation, then the findings will be there in the infrascapular area, also in the, okay, Sarthak wants me to repeat. See, the right lower lobe surface marking, the places where the right lower lobe is present is in the interscapular region, infrascapular region and the infraaxillary region. As I told you, lower lobe will not come into the anterior part of the chest. So if it's a dense consolidation, you will have increase in the tactile vocal fremitus in the interscapular, infrascapular and infraaxillary. But in this case, the X-ray what I showed you, it is a patchy consolidation. It doesn't appear to extend toward the lateral part of the chest wall. So what I am telling is that in this X-ray, in the patient who has this X-ray, probably you will have only increase in the tactile vocal fremitus only in the right infrascapular region. Only in the right infrascapular region. Okay. Fine. So now going into the, so what you need to understand is the undisplaced mediastinum, no change in the volume loss, but increase in the tactile vocal fremitus. Okay, so that is a finding, and of course chest expansion will be affected, that we have already found out in the inspection. Now going to percussion. So what will be the findings in percussion? What will be the findings in percussion? Dullness over the area of consolidation. Okay, again which area? Which area you will get the dullness? Dull note in the infrascapular region. Infrascapular region. Very good. So you will get a dull note in the right infrascapular region. Looking at the opacity, probably that is the place where you will get the dull note. Now, if it is a dense right lower lobe consolidation, let's assume that the patient has a dense right lower lobe consolidation. Then where all will be the dullness? If it's a dense right lobe consolidation, where all can be the dullness? So it will be interscapular, infrascapular and infraaxillary. Very good. Okay. So that will be the finding in. Very good. So that is the finding you will get it. See, sometimes you will get a impaired note. Sometimes you will not get a dull note, but you will get an impaired note. Slightly abnormal, slightly dull. That is also possible. So in consolidation, the percussion note will be impaired to dull. But at your level, you just remember only dull. Don't confuse with. I'm just telling you because there is a terminology called impaired dullness. Sorry, impaired resonance. So we tell it as impaired percussion note, impaired resonance. So that's an intermediary term we use. But at your level, you remember it as a. Okay. Now going into auscultation. So what finding you may get in auscultation? In right lower lobe consolidation, same patient, what findings you may get? Okay, Shruti has mentioned crackles in the right lower lobe. Now, I want a complete, if you see there are so many components we need to look in the examination. So try to give a comprehensive finding. So Roshni has mentioned decreased breath sounds in the right infrascapular, crackles, bronchial rhythm, increase in the VR. Okay. Now auscultatory findings in consolidation is very much variable. Okay, I'll give you the classical description first, but I'll tell you why the variations are very, very high. So you expect the breath sounds to be in dense consolidation, the breath sounds may be marginally decreased because air will flow, but it will not go freely through the airway because alveolar exudates will be there. So since there the normal expansion and recoiling of the lung is affected, breath sounds will be, intensity of the breath sounds will be slightly decreased in the infrascapular region and the infraaxillary region. You may have a bronchial breathing. You may have a bronchial breathing at any point, any place. It can be all over or only in one place. You may have a crackles. So it can be early inspiratory or late inspiratory or expiratory. The spectrum is quite broad. So it can be inspiratory or expiratory crackles. Generally, wheeze is not heard and vocal resonance will be increased. So already I have discussed that part. So this will be the finding. Okay, so I'll just repeat the finding. Bronchial breathing is generally, the breath sounds are generally decreased over the affected area. Bronchial breathing may be present. Crackles, both inspiratory and as well as expiratory, is possible. Okay. Now I'll try to, so is that clear? I'll tell you, before I go into the subdivision in the bronchi. Okay. Why bronchial breathing, no tracheal shift? Okay. See, bronchial breathing is basically occurs when the some amount of lung actually expands and recoils. Bronchial breathing is not always present there. But here the problem is there will be delay in the elastic recoil. So when the lung is consolidated, the elastic recoil has to be of more effort, isn't it? So it will not be spontaneous. So elastic recoil will be more of a active. So what will happen? The inspiratory phase will be there and the expiratory phase will get prolonged. So because the expiratory phase will get prolonged and moreover the alveolar is filled with exudates, and since the elastic recoil is not spontaneous, you will get a pause. So the pattern of breathing will be like this: inspiratory phase, a pause, and an expiratory phase, and the inspiratory phase duration, the expiratory phase duration will be the equal. So that is why you get bronchial breathing there, but bronchial breathing is not always required. Manasi wanted to know, repeat why increase VR. See, already I told you, VR is increased because a diseased lung, especially the consolidated lung, will not filter all the frequencies, will not filter any of the frequencies produced at the vocal cord. So what happens? All the sound which is produced at the larynx will reach the chest wall. As I told you, a normal lung will filter the low frequencies. It will filter the low frequencies, and therefore that is why we are getting increase in the VR. Okay. Now I just want to conclude with one. Okay. So now is it clear now the findings in the consolidations? I'll just repeat the findings again. Inspection, the only finding you will have in inspection and right lower lobe consolidation will be decrease in the chest expansion. No mediastinal deviation, no change in the volume. When you palpate the individual, again no change in the volume. There will be decreased in the chest expansion and there will be increase in the tactile vocal fremitus. This will be the only two findings in palpation. In percussion, you will get a dull note. If it is a dense consolidation of the right lower lobe, you will get it in the interscapular, infrascapular and infraaxillary. In this case, it will be present probably in the infrascapular region alone. Okay. And the percussion note will be dull. On auscultation, breath sounds is likely to be marginally decreased. If it is a dense consolidation, it will be decreased in the infrascapular, interscapular and infraaxillary. In this case, it will be breath sounds will be probably decreased in the infrascapular region alone. Bronchial breathing may be present at the same location. Crackles, entire spectrum, inspiratory or expiratory crackles may be present. Wheeze is not usually heard. Okay, and no other added sounds will be actually heard. VR will be the same thing as of vocal tactile vocal fremitus. Is the findings, inspectory findings in lung consolidation clear? Any doubts you have on the clinical signs in lung consolidation? Okay. See, so it may look quite simple, but please go ahead and revise. So we have discussed the clinical signs in two pathologies. One is lung consolidation, another is pleural effusion. Okay, so we'll take up the other pathologies gradually. And the reason I started respiratory system is understand the findings in respiratory system is quite difficult. When you will know when you examine the patient, you will know it will not be straightforward. It's quite confusing when you examine the patient. So only when you have concepts, you can put things together and maybe come with a differential diagnosis. So Rachana has asked a question. So do vocal resonance and vocal, yes, vocal fremitus and vocal resonance follow the same principles. See, for all practical purpose, forget about the tactile vocal phragmitis. Just concentrate on the vocal resonance. That's all. Clinically, you just, Shruti has mentioned, still, sir, will we hear any added sounds in pleural effusion? See, added sounds, pleural effusion, added sound depends on the expansile capability of the non-compressed lung. See, for example, if in the left-sided pleural effusion, if there is a mild kind of a passive collapse of the upper part, you may have some crackles. Or when there is an underlying lung pathology also, lung consolidation leading on to pleural effusion, then you may have some added sounds. So generally, we think about when the added sounds are present in pleural effusion, we think about the possibility of underlying lung consolidation also. Okay, so I think we have come to an end. So today I have given you the findings in clinical examination of lung consolidation and left-sided massive pleural effusion. Please do revise. I'll try to put some quiz related to this. So the next class will be on Thursday, where we'll be continuing the clinical signs in respiratory disease. Thank you, everyone. So I'm just closing the recording.